So this was a 56 years old male, known case of chronic smoker, hypertension, diabetes, presented to the emergency department with a ST elevation in 2-3 AVF, lead 3 is more than 2. And obviously you can see the RCA, large burden of thrombus is there right from the mid proximal RCA, and there is no flow in the distal RCA. So it is very difficult in the chronic smoker patient. There are the chances of no flow, reflow and all. So after explaining all the risk involved and all, we proceeded for the angioplasty. After all clearances, you can see how bad the engagement, and there is anomalous origin of the RCA. So this was a right radial route with the JR catheter 3.5 into 6 French, and you can see how bad the thrombus was in the RCA. So what I decided, you cannot see the distal RCA after the bifurcation. There is no PLV, PDA. You cannot see because there was a large burden of thrombus. So what I decided is to do the balloon daughtering. I was trying to put the wire. This is a simple workhorse wire, but I was unable to cross the wire from this point. And at this point, you can see some flow has come, and I could see the PLV, but the lesion, the plaque rupture site was heavily loaded with the thrombus. And then I could cross the wire, but you can see there is no flow, very minimal flow in the distal RCA. So I decided to do balloon daughtering and balloon inflation. So in this frame, you can see I was doing balloon daughtering. Balloon daughtering is a simple uninflated balloon to and fro motion, so that in the hope of getting flow. However, after balloon daughtering, there was no flow. So we lost the flow in the distal RCA again. Then we did the predilatation at the point where the plaque rupture probable. We did the predilatation for 2-3 times with a multiple balloon. So however, we lost the flow again. This is a problem in the chronic smoker with a large thrombus burden. So you can see how the contrast was staining over there. So I did again balloon daughtering. Aggressively balloon daughtering was done, and we could establish the flow. You can see after aggressive balloon daughtering and balloon predilatation. So I decided to put a stent just before the bifurcation, where you can see the site of plaque rupture. So if you see the size in the distal RCA, this is almost around the 3. So we deployed the 3 into 28 stent at around 40 atmospheric pressure. Nominal was 8, RBP was 16. And now the flow established with slow flow, sort of slow flow was there. So this was the final scene, and you can see how large the PDA PLV and the super dominant RCA. So this was the sort of not primary, but it was the angioplasty to RCA in this thrombus loaded RCA with large burden of thrombus. Thank you.